there is a little bit of a correction of the title. After I sent off the topic, I realized that it is impossible to talk about the management of upper urinary tract stones in 1 hour. So today I'll focus on kidney stones, and if we have time, we'll deal with the management of proximal ureter stones. Okay, I was told to put in some learning objectives to fulfill CME requirements. So I've decided to put it in a question form because I think that putting it in a question form is simpler, easier to understand, and it is probably clearer. So I apologize for this very cliche slide. If you already know this, please ignore me. But I still use this as a reminder from day to day in making clinical decisions. So I think that being a surgeon, you have to be a clinician first. And we have 3 people to answer to. Along the way, there will be distraction, noises to try to sway us from making the right clinical decision. But ultimately, we're answerable to the patient, to our students, and to ourselves. Cliché, forget it. Okay, now the first clinical question. Can we leave asymptomatic, uncomplicated stones alone? Okay, so that's our first. We have 2 questions today, so this is the first one. So when I talk about uncomplicated, asymptomatic renal stones, obviously I'm not considering solitary kidney. Too precious to be left alone. Occupation, if you're a MiG-29 fighter pilot flying a $1 billion plane in the sky, you really do not want to crash the plane because of loin to groin pain. Or if you're an oil rig driller in the middle of South China Sea, where the nearest facility is like 100 miles away, you better make sure you do not have any stones in your kidney. And staghorns, notorious for causing progressive kidney deterioration, and definitely not ureter stones. All right, the first study. Now I'm just going to highlight important parts of the slide to you, so you don't really have to read the whole thing. So we have this study from Turkey, prospective long-term follow-up of patients with asymptomatic lower pole calaceal stones. They want asymptomatic adult low calaceal stones, so they've excluded a whole host of other conditions. They have excluded stones from other locations, congenital anomalies, solitary kidney, and renal failure. And of course, if there's obstruction, they will exclude the patient as well. So evaluation, everybody gets a CT-KUB, an IVP, 6-monthly follow-up, and they image upper tracts, CT odd years, ultrasound even years. Right. They have defined disease progression as pain, stone growth, dilatation of the urinary tract system, infection, and a persistent gross hematuria. Now, look at this. We talk about disease progression. They vary in severity. So what if there's stone growth, you might ask? Pain might be a more logical reason for one to intervene. Definitely dilatation of the urinary tract, definitely urinary tract infection, and maybe gross hematuria. But what if the stone has grown 1 millimeter? Is that an indication to intervene? So the results. We have 24 patients recruited with 27 renal units with a mean follow-up of almost 5 years. The average patient in this study, 4.5 years, is subjected to 3.5 CT scans. Now, the radiation of CT scan has been underestimated. Over the years, we find that patients with renal stones that has been subjected to CT-KUB might even be subjected to the radiation comparable to someone who has survived the Hiroshima bomb. A busy slide, I'm sorry, but what I'm trying to illustrate here is basically this study has tried to subject the patient to observation for small stones as small as 2 millimeters and for big stones as big as 1.5 centimeter. Now, progression, they found that 1/3 of their renal units have an increase in stone size. The mean increase in stone size is 7.2 millimeter, and there is no significant correlation between the stone size at initial presentation and the rate of growth. 11.1% require intervention within the 2-year period. There is no loss of life or loss of kidney, no pyelonephritis in this series. Now, intuitively, if the renal stone is bigger, the chance of it passing out spontaneously is smaller. So this is demonstrated in this study. And look at this, the last point. If you have a renal stone, asymptomatic, uncomplicated, and you choose not to do anything, you get a 20% chance of it coming out on its own. Not too bad. 20%. So that was just a observation study, follow-up patients, without any randomization, and is certainly not, is not randomized. So now we look at the second study, a prospective randomized trial of management for asymptomatic lower pole calculi. It is an RCT. We have 99 patients randomized to shockwave, PNL, and observation. 33 patients each arm. So they've basically excluded the same type of conditions. And initial evaluation, we have IVP and DMSA. And the follow-up is quite rigorous. 3-monthly KUB X-ray, CT, renal scintigraphy at 6 weeks and 12 months. Now for the PNL and shockwave group, a non-contrast CT scan of the abdomen was done at 3 months and 12 months post-intervention. So it is a standard technique for PNL, open system with balloon dilatation and amplas sheath, all single tracks, and they use the Swiss lithoclast master. Now the Swiss lithoclast master is a combination of your ultrasonic as well as your pneumatic. So it is a concentric configuration. You have a hollow tube that delivers your ultrasonic energy, and you have a stick, a pneumatic stick in the center. So you can control whether you want both or just a single energy. And shockwave without anesthesia, gradual progression of shockwave energy, and evaluation by KUB X-ray 1 week after the shockwave. And for shockwave failure is a 3 strikeout. So 3 sessions without stone fragmentation is considered a failure. And progression is defined as symptoms related to obstruction, stone growth, recurrent infections, and gross hematuria. There is no difference in the size of the stone treated in each arm. So that makes a comparison more sound. And intuitively, if you treat a stone, you'll get higher stone-free rates. And if you don't treat a stone, you get lower stone-free rates. So here are the results. Now, similar. The previous study, we had 11.1% intervention rates. And in this study, we have 18.7% intervention rates for increase in size, UTI, and symptoms. And the median time to intervention is slightly less than 2 years. And only 1 patient had spontaneous passage. And there's no renal scarring in this series. So the PNL, 100% stone-free rate at 12 months. That is high. We were always told that nothing is 100%, but they managed to achieve 100% in this series. So when you see such a result, you really have to ask yourself a few questions. What is the modality that we use to image the patient? And at what stage after the operation do we do the imaging? When I first met Ben Chiu, Ben, about 2-3 years ago in a meeting, I listened to his presentation, stone-free rates after PNL, and the percentage was low. And I was surprised. Why is someone presenting negative results? And I later found out that in VGH here, we are doing CT scan first post-op day. So over the years, I think it's important to know that people have been tweaking what constitutes stone-free rates. And I think it's a very important concept. Less than 4 millimeters, they consider stone-free. You do a KUB X-ray in 2 years' time, you don't see any stones, it's stone-free. So I think one of the benefits of doing a CT scan after PNL is that it all depends on how rigorous you want to be, all right? And in this series, we happen to have 100% stone-free in 12 months. Now, 1 patient needed a transfusion, and 1 patient had post-op fever, and 1 patient had lower pole scarring, but no change in renal function. Now, in the shockwave arm, 61.3% stone-free in 12 months. 1 patient had Steinstrasse, and 1 patient had lower pole hematoma. 5 patients had lower pole scarring. All of the 5 patients who had lower pole scarring had experienced 3 sessions of shockwave. So some more data on observation of small renal stones. So except for Glowacki, the intervention rate is similar. It's in the region of 20%. Now, there is a huge discrepancy between progression rates and intervention rates. So does it mean that a majority of the progression rates is simply increase in stone size? So there will be no discussion if we are sure that shockwave is 100% efficacious, URS is 100% effective, and they are 100% safe, and they come at no cost. There will be no discussion. But we know that shockwave is safe, but it's not 100%. Lingerman actually found that 8.2% of patients develop hypertension within 1 year after shockwave. This is an old machine, this is an old study, but this is to show that shockwave is not as safe as what we think it is. And William concurred with another study with finding patients, 8% of patients develop hypertension within less than 2 years with documented decreased effective renal perfusion flow, plasma flow. So there are other complications of shockwave like Steinstrasse and UTI and hematoma. And the stone-free rates of shockwave is not fantastic. David Albala from Duke University showed that stone-free rates for shockwave is in the region of 37%, and this is concurred by Francis Keeley. It shows that it's a mere 28%. And ureteroscopy has its own set of complications, possible complications, ureteral perforations, strictures, anesthesia, and definitely cost. All the guide wires, access sheath that we've been using, it comes with a price. And you have really now to compare, to find reasons not to intervene. Is there a cost for observation? Definitely. All the CT scans that you do, the clinic visits, and not to mention the radiation exposure follow-up, anxiety, and employment considerations. So now you have the data, and you got to ask yourself, if you have this, I don't know how much of a gambler you are, but 60 to 70% chance of not requiring intervention, it sounds pretty good to me. So are you going to take it? And if you are, how are you going to advise your patient? All right, so question number 2, the surgical option. So if you've decided to intervene, so what is the surgical option? You have open surgery, you have shockwave, URS, PNL. Now, I've the opportunity to work with many great residents in the Stone Center. And those people who have been to the Stone Center will know that whenever we pull out a sizable fragment from the tract, there will be a ooh in the room. Okay, they'll be so excited. Okay, especially the residents. So I can imagine if I've not done many of these open surgery. Okay, I can imagine how it would be like to hold. Nothing beats the feeling of holding a stack horn in your hand. I think the sensation must be quite surreal. Okay, shockwave. Newer machines may be safer, a better understanding of shockwave mechanics, which will allow us to choose our patients better. And people have come up with all kinds of auxiliary maneuvers just to improve their stone-free rates. And URS, we have better scope optics, we have scopes with passive and active deflection, smaller scopes, access sheath, and we have improved laser delivery system. We have baskets as small as 1.7 millimeter. That's how small things are. Now, PNL, improved imaging, balloon dilatation, and open MPLAS system, as opposed to the closed one, that actually, the open system allow us to alleviate the chance of TR syndrome in PNL. All right, so you have your different options, ureteroscopy, shockwave, and PNL. Now, why do we not compare PNL with ureteroscopy? Down the next slide we'll show. So which procedure is better, big stone, small stone? Anyone? Ureteroscopy and holmium laser? It will take forever. Okay, so maybe in the near future we will not be faced with a dilemma of ureteroscopy versus PNL. Okay, and conversely, such a small stone, would you want to do a PNL? Now, this is a very important diagram I still use this diagram. Not so much to select my patients for ESWL, but more to guide myself for my puncture, or the punctures that I do in Singapore. What is the problem with the lower pole? So people have come up with all sorts of postulations. Is it the width of the infundibulum? Is it the length of the infundibulum? Is it the stone load? Is it the dependent position? Is it the infundibulo-pelvic angle? So, in a nutshell, it is gravity. It is in a cul-de-sac that is gravity dependent. So you can break the stones all you want, it just will not come out, unless the patient walks on his hands all the time. So, big stone, lower pole. Now, historically, the PNL came before shockwave. And early PNLs were a little bit crude in terms of technology, limited experience, and definitely much more complications than the PNLs we know today. Until Mr. Chelsea came and reported the first clinical data of shockwave. And he had 90% of stone-free rate. That is amazing. More amazing than ShamWow. Was it novel technology phenomenon then? Because after this report, the stone-free rates of shockwave lithotripsy came down after this initial report. So this is the first critical analysis, meta-analysis of shockwave lithotripsy. It is a meta-analysis. It is comparing the PNL, the stone-free rate of PNL versus shockwave. It is using the HM3 machine, and it found that the PNL is superior, with a stone-free rate of 90% versus 56% with statistical significance. And another important thing is that PNL, as opposed to shockwave, is independent. The stone-free rate is independent of the initial stone burden. And a subgroup analysis find that PNL, as the stone gets bigger, the stone-free rates get smaller. So it is inversely correlated to the initial stone burden. Right, this is the landmark study that make things exciting. Now, the lower pole study group came up with this study. It is a multi-center randomized controlled trials looking at adults with lower pole stone. They're trying to find out which is better, shockwave or PNL. So they have excluded a few conditions. They do not want any congenital anomalies. They have excluded failures of shockwaves due to extreme body habitus, no renal insufficiency, and no transplant kidneys. Now, follow-up, 3 months post-intervention and then annually for 3 years. Nephrotomogram, serum creatinine, treatment failure is defined as a treatment with a procedure other than to which the patient was originally randomized. We have 128 patients, and there is no difference in the average stone burden in both procedures. Retreatment was correlated with stone size as well, but not for PNL. Now look at this diagram. For all sizes, the retreatment rate is obviously higher for shockwave. And within the shockwave arm, as the stone size gets bigger, the retreatment rates get higher. And as for stone-free rates, it's the same thing. For shockwave, as the stone gets bigger, the stone-free rates get smaller. And then PNL doesn't seem to be affected by the initial stone burden that much. And of course, PNL is definitely associated with a significantly longer hospital stay. Let's take a look at the individual complications. You have urinary tract infection, obstruction, colic, hematoma, Steinstrasser as well, and UTI, ileus, sepsis, hematoma, obstruction, perforation, transfusion, and AVF, which is just one patient out of the 128, less than 1% of PNL. So to summarize the results of this landmark study, lower pole 1, it is a little bit like a guideline in this case. For lower pole stones more than 10 millimeter, shockwave gave only 33% of stone-free rate, and PNL gave more than 85%. Now, retreatment, PNL is superior with 16% versus 9%. And for auxiliary procedure, again, PNL was superior, 16 versus 2%. And for the shockwave group, the stone-free rate is inversely correlated to the stone size, and retreatment rate rises with stone size. Now, we have seen data for the big stones. Now we talk about the small lower pole stone, which we have agreed that we probably will not do PNL for. So that leaves us with shockwave versus ureteroscopy. And then we have another RCT. Methods. It is a multi-center RCT, and they want adults with isolated lower pole stones less than 1 centimeter. So they have a long list of exclusion. So in a nutshell, what they want is this. No congenital anomaly, no solitary kidney, no renal failure. A simple, isolated, less than 1 centimeter lower pole stone. Everybody gets a CT, plus, minus, and IVP. Thin cut CT was used for follow-up 3 months after treatment for assessment of pain, stone-free status, and pain assessment, time to work, time to normal activity. So the results. Same type of patient as far as body habitus is concerned, and there is no significant difference in the mean stone surface area. Shockwave was found to be faster. Intuitively, that's correct. 89% stented after URS versus 3.1% in the shockwave group. In the URS group, 17% had balloon pre-dilatation and 69% used excess sheath. 1 shockwave patient had PVCs, 2 URS patients had ureteral perforations treated by stenting. There is no significant difference in retreatment rates between the 2 arms. So again, we see there is no difference whether it is stone-free, absolute stone-free, or stone-free with fragments less than 4 millimeters. There is no difference in shockwave versus ureteroscopy in this clinical scenario. So the patient's perspective, which procedure does... Yes.
You know what machines they're using?
This is a multi-center. There are altogether, I think, 12 models. So it is a multi-center trial, so they have many different types of machines. So now is the time to ask our patients, after knowing the data. So what does the patient like? To the patient lying on a machine with a water bath, sounds very enticing, all right? Versus, I'm going to put a scope this long into your penis, okay? So yes, in the QOL, the patient seems to like shockwave better. Mean days to driving, return to strenuous activity, to work, seems to favor shockwave. So the summary, ureteroscopy seems to be superior as far as stone-free rate is concerned for small lower pole stones, but it is not statistically significant. And complications rate is not different, there's no difference in the 2 arms, and the QOL seems to favor shockwave. So we got to ask ourselves, why is shockwave the common enemy? Why is it the punching bag of endourology? Maybe because it is simple to do, short learning curve, safe, sound, and in the past 20 years it's enjoyed so much popularity. It seems to be the ideal solution to stones in the kidney. But it has got such variable results with varying protocols, machines, indications, that inevitably it is, I would say, subjected to abuse. Again, this is to remind us why the lower pole stone is so important. Now, I did a little search on what people have been doing to try to make shockwave better in clearing stones. So we have come up with PID, percussion inversion diuretic. You hit the patient, you turn him upside down, and you give him lots of fluid. Hopefully, we will get the stones to come out. And people have put in tubes either antegradely or retrogradely and irrigate, put in water fluid to try to to flush the fragments out, and stir up therapy. This is amazing. So after you've broken the stones, you subject the patients to more shockwave. Hopefully you can rake up the dust, and hopefully some of the dust will fall out. Novel. So my message, 30% treatment chance during conservative management of a small asymptomatic renal stone. So if it is not complicated renal stone, there is no symptoms, there is 30% that you might need treatment. But is anything lost? Because none of our data shows that, that there is scarring or renal impairment as a result of the delayed treatment. Okay? So you've got a good 70% chance of not requiring something done. And for lower pole stones, more than 1 centimeter, data for PNL is strong. Gravity will prevail. And lower pole stone less than 1 centimeter, there doesn't seem to be a lot of difference. But in the studies that we reviewed, they did not really take into account the money spent. And of course, QOL, we know what the patients want. I think we have time. Let's talk about the proximal ureter. So, looking through the literature, it is difficult to get a quality study on treatment of upper proximal ureteric stone. I found one. A matched pair analysis of ureteroscopy versus shockwave in the treatment of upper ureteric calculi from Edinburgh. Now, it is a retrospective data with prospective matching of subjects. So they did a retrospective collection of data, and with the data, they tried to match patient for the parameters of stones and some other factors I'll show you later. So they included patients with proximal ureteric stones. They excluded UPJ stone and any patients who had undergone a prior drainage procedure. They used the Dornier compact machine. And ureteroscopy was performed with a semi-rigid flexible with either laser, EHL, electrohydraulic lithotripter, or pneumatic. Now, they managed to match 27 patients. And there is the only significant difference in the initial parameters is the age. Okay. Results, excuse me. From a 4-year period, they managed to find 220 patients and 1,259 patients undergoing URS. But only 27 pairs were matched. Okay? There is no statistical significance in the stone-free rates or success rates. Sub-analysis of holmium laser ERA found only 9 pairs. All right, so I really do not want to comment more about this. But the author said that holmium laser resulted in an all-round improvement in the outcome measures of ureteroscopic management. But it's just too little patients to make a significant comment. So my critique is, it is a study, I think it's a truthful study. A study with a robust statistical model, but small numbers. And the absence of critical information like the BMI, as well as a wide variety of energy sources in the URS group. These are some of the shortcomings of the study. That's all. And I would like to thank Ryan and Ben for their help in this presentation. Thank you.